I was like, oh my God, we're curing heart disease with a knee injection? Yes, that is good doctoring.
PRP is the one that's been out the longest. Shockwave is the new kid on the block. A lot more data before we're going to say that Shockwave is going to completely displace or knock PRP out of the way.
How are you positioning yourself for this technology? Welcome, everybody, to Conversations in Regenerative Medicine. I'm so glad to have you on this really exciting topic that is near and dear to my heart. I wanted to just give you an idea that we're going to be hearing from renowned expert John Ferrell. He's also my friend. And this is an informal conversation. We're going to learn all of the dirty secrets, the tips and the tricks, and what you don't really get to read in the papers. And we're going to be exploring these controversial topics. And I also hope to give you some actionable insights that you can implement in your practice and be able to ask live and in person these questions, these things you're wondering about that we don't always get to sit down with John and say, hey, John, what do you think about this? What do you think about that? So I'm really excited. I'm going to get started, but I really do want to just remind us why we're here. And this may come as a shock to you, but you are not living up to your potential. Here's what I mean. Successful integration of orthobiologics is hard. A lot of people, we don't know all of the science. We don't know all of the techniques. We don't know about cash business, marketing, sales. And honestly, this is hard. Maybe some of you are struggling to figure out how to capitalize and be successful in this $4 billion orthobiologic market out there. I had this epiphany that orthobiologics is the best treatment for my patients. Then the next step is, how are you successful at this? But ultimately, we need to know how to win. So let's get down to business. And we're going to be asking John the first burning question. John, I wanted to know, there's this conversation that's happening about PRP versus Shockwave. A lot of people, and Shockwave has pretty much flooded the market recently. And so some people are saying that you don't even need PRP and that Shockwave will do everything that PRP can do and more. What are your thoughts on this?
Ariana, first of all, thanks for having me. I look forward to this talk and I appreciate you having me on. I think when we talk about Shockwave versus PRP, PRP is the one that's been out the longest. We have level 1 evidence to use PRP for multiple different tendinopathies, including lateral epicondylitis, glute med tendinopathy, rotator cuff tendinopathy, Achilles tendon tendinopathy, patella tendinopathy. We've got the evidence, we've got data that supports it, we've got the evidence to back it up. Shockwave is the new kid on the block. And so I think we
in a big way, right?
Yeah. So I think we need a lot more data before we're going to say that Shockwave is going to completely displace or knock PRP out of the way. I think that there's pros and cons, and a lot of these things we always want to tailor it to the patient, right? So if I'm managing somebody that has a tendon issue, typically we're going to A, evaluate it with a good physical exam, B, use an ultrasound to diagnose to see if do we have tendonitis, tendinopathy, partial thickness tear, full thickness tear, right? Get a good diagnosis and maybe add an MRI if we're not sure with our ultrasound diagnosis or skills. And then based on that, we usually start off with conservative care, but I lay out all the options and allow the patients to choose. I'm in Washington, D.C., so everybody is type A, wanted to be fixed yesterday. So some people are like, hey, I hear you with the physical therapy, but why don't we do an injection today and I'll still do therapy. So I give them those options so they can pick and choose. A lot of them say, hey, start off with physical therapy first. If you're not better, come on back and then we can try some things. And then you want to tailor it to the patient, right? So some people can't come in once a week for 4 to 6 weeks to get Shockwave. That's a time commitment. They're taking time off from work and they'd rather say, hey, just give me one shot. Let me see if I can do it once and done or repeat it in 6 weeks. And so you have to tailor some of this to your patients, and then vice versa. Some people are like, hey, I don't like needles. let me try a little bit of shockwave first and let me see how things go. But really, to answer your question, where I think the future is going to go, it's going to be a combination, right? So if we can say, hey, you have a chronic tendinopathy or a small partial thickness tear of your rotator cuff, what we're going to do is we're going to package this together. I'm going to start you off with PRP, ultrasound guided directly into that tendon tear or directly into the tendinopathy. We're going to look to see if there's any other associated pathology, i.e., biceps tendinosis, instability of the labrum. We're going to treat those areas also. And then I'm going to combine shockwave with that for 4 to 6 treatments after the PRP. And then we'll see you back in 6 weeks. And that's what I think we're going to start to move towards, and find that we'll get better outcomes when we actually combine these things together and not try one just separate on its own.
Yeah. And so are you currently stacking them? How are you talking to your patients from just like a money standpoint, from a charge standpoint? Are they standalone treatments? Are they part of a package? I'm struggling myself with this. Like, how do we incorporate this technology in a way that makes sense from a financial standpoint, from the clinic, as well as from the patient standpoint? So how are you doing that?
Yeah, so I think that we're in a unique situation. We're going on in February, we'll be open for 11 years. So we've got patients who have been getting regenerative treatments for years and years. What I'm starting to do is I'm starting to put some of these together as packages, right? Long and short, I said, if I had a partial thickness rotator cuff tear, what would I do to myself? And I put together a package that has supplements, that has shockwave, that has PRP, and this is what I think is the optimal package. And I'll present that to the patients. Now, because I have patients that are like, that's cool, doc, but I had one PRP shot 5 years ago and that fixed me, I just want to do that again, then that's an option for them. Then you have somebody else who's just, hey, that sounds okay, but I just want the least invasive thing you have. I've already tried physical therapy. I wasn't successful. What's the next step up before you start putting out needles? I say, come on in. You can see my PA for 4 to 6 visits. He'll do the shockwave for you. Come back and see me after the 6 weeks. We'll see how you're doing. And if they get better, great. If they don't, then we know the next step is going to be an injection from that standpoint.
That's such a great plan to have that flexibility one way or the other. Now, how do you talk to your patients? I haven't found that Shockwave is covered by insurance. Are there any insurers in your area in DC covering Shockwave?
No, shockwave is
Oh,
purely
cash.
cash out of pocket.
Yeah.
And we often offer a free trial.
Okay.
And so we just say, hey, come in, try it out. If you like it, because usually you'll get an analgesic effect shortly after that treatment, right? So people are like, wow, my rotator cuff feels better or my hip feels better. And usually they're sold and they're like, okay, we're going to continue to try that out for 4 to 6 visits to see if it gets me where I need it to be.
This has been flooding the market, and this has been available to non-physicians. How are you positioning yourself for this technology? How do you speak about it when they're like, yeah, I went to my chiropractor down the street and he pulled out his shockwave, and my physical therapist used shockwave on me, and everybody's using shockwave everywhere. How do you position yourself?
So there's a couple of things. I think one, we've had shockwave for about 5 years now.
So it ain't new.
When we first got it, we really marketed as we were the only people using shockwave above the knee, because the only people in the area that had shockwave were podiatrists. They had pretty good data in foot and ankle, Achilles tendinopathy, plantar fasciopathy, right? That this stuff was beneficial and it worked. And so we're saying, hey, we can use this in other places. We can use it for your hip. We can use it for your low back. We can use it for your shoulder. So that's how we kind of position ourselves in the market, as we were the people that could do it above the knee. But the other thing is that we are literally the regenerative experts, right? So when people come to us, they come to us for all their regenerative medicine care. And so we're the people that can say, hey, this is the lowest level, but then if you need to step up to prolotherapy, to platelet-rich plasma, to MFAT or BMAT, we have the expertise. We can do that. What we can also do is use musculoskeletal ultrasound to monitor things over time to see if things are improving, right? So if you have a 1.0 centimeter Achilles tendon that's super thick, we can do 4 sessions or 6 sessions. I can repeat the ultrasound and say you're down to 0.8, you're moving in the right direction. So not only are you feeling better, but you're actually seeing the benefits. You're seeing ultrasound changes that kind of reinforce what you're feeling.
What shockwave device is the best? What is your shockwave device of choice?
So I think that the one that is the best is the we don't know. There's kind of two major ones that are out there right now. One contains a radio shockwave and a focus shockwave. So radio we like to think of as a wide paintbrush that covers a large area. And it's a really loud machine, and it's like a little mini jackhammer. Creates these ultrasonic waves that spread out in a very wide radial kind of manner. If you threw a pebble in a pond and those waves spread out and go out wide. Then to make that most effective, you need to pair that with focus shockwave. So focus is the opposite. So we're focusing into a discrete point. It's also what I call my truth finder, meaning if you put that focus shockwave over an area that doesn't have pathology, you usually don't feel anything. As soon as you get it over an area of tendinopathy, over a partial tear, it lights that patient up. You're getting it directly on the spot that has pathology. So when we're using the one device, you want to pair those two together in order for the best outcomes. Then there's another device that's both focused and radio in one, is the way I think of it. It has focused waves with an unfocused wave over top. So it allows you to both hit a wide area like a cone, but then also pinpoints different areas at that different depths. To my knowledge, I've seen no head-to-head study comparing the two. And from a time standpoint, the second one seems to be a little bit faster because, hey, you only have to use one machine rather than two. But from a research standpoint, the one that has both radio and focus has more data out there to support it. So I think that we don't know yet. I think that there's some pros and cons with both of them, but the one that has the most data is the one that you're going to have to spend a little bit more time with and use two different machines.
Great. Thanks so much. Awesome. I have another question for you, and this is a little different. Do you think the regulation of the regenerative medicine in the last 5 years is helping to advance the science, or do you think it's stifling innovation?
Obviously, we have FDA, and part of their goal is to keep people safe, to make sure that there's not too many cowboys out there. It's not the Wild West. We're not having issues. And obviously, we've had a history of having issues in the past, right? We had people who've gone blind, people injecting things into weird areas, sterility issues. So we do need regulation in order to keep things safe, to make sure things are done in a proper manner. That being said, FDA is not set up to manage or regulate regenerative medicine. FDA is set up to manage drugs and have things go through a drug pipeline. And for example, let's go look at hyaluronic acid. So hyaluronic acid came through, they did one of these FDA studies that usually runs somewhere around $20 to $25 million. And they did a study for an indication, which was osteoarthritis of the knee. And they found that it was equal to or superior to saline and or cortisone, because that's, you don't have to be much better than them, you just have to be equal to them.
Perfect.
And with that, they got approval for use in knee osteoarthritis. Can we use HA in shoulder arthritis? Can we use it in CMC? Can we use it in hip? We can. Those are off label. So you can't use it with FDA clearance because they didn't pay FDA again to get the hip approved. They didn't pay FDA again to get the shoulder approved. And why did they spend that money? Because they could patent their drug for 3 years, where they're the only one that can use that drug, so they can recoup that money before it becomes generic. The problem is with PRP, with MFAT, with bone marrow, these are the patient's own cells. We can't patent that, right? We can't say, I patent your blood and you have to buy your blood from me for the next 3 years where I can recoup my $20 million investment. So Orthobiologics doesn't fit into this system. And so that's where it's going to be an issue. Now, interesting enough, we have a company out there that does MFAT, and they make kits for MFAT. And they were willing to take this bet that are going to pay this expensive amount to do an FDA study for knee osteoarthritis in hopes that we can sell enough kits in order to recoup our investment. And so we'll be interested to see once they submit to FDA. I think that's going to go through, and they'll probably be the first regenerative medicine approved in the States for use that'll have an FDA indication. But it will only be for one indication, it'll only be for osteoarthritis. So then if people come to me with rotator cuff tear, it's still not going to be covered by insurance. So this is the problem with our system, specifically when we're dealing with orthobiologics.
Overseas, there's a lot of other options. And it seems like there's a lot more collaboration and opportunity for growth, but still within a safety environment. Do you feel hemmed in being in the States and not having that ability to use the things that are out there?
Absolutely. Just stem cells, that word in general is just a hot button topic, right? They imagine what stem cells are. Are you getting it for babies? What's going on? Or they see stem cells as one of those hot button topics. And so there's a lot of restrictions that we don't see elsewhere where they're actually investing in this. They see this as the future. So a lot of countries in Asia are putting a lot of money into this. Not only are they looking to do it in a safe and effective way, but they're also looking on how do we do this in a culture expanded way, right? And so we're not sure if the number of stem cells is the magical key, but we think that dose does matter. And so if we can now actually take your stem cells from your bone marrow or from your fat, we can culture expand that, and we go from 1 million to 15 million. Are we going to get better outcomes? Some of the data from Asia seems to show that yes, we will. And really, that becomes probably the future of what we see with stem cells over the next 5 to 10 years, right? You get somebody's stem cells once, you bank it, you culture expand it, we can re-inject it, and then they get an injury a year down the road. Guess what? We still have it banked. We call the bank up, they mail it to us. Now we can still use our autologous cells, your cells that are culture expanded, inject it back into this area there. And can you imagine a world where we do this instead of cortisone, where we literally can change the progression of osteoarthritis by saying you have it when you mild or moderate. We start treating these patients with their own cells, and 30 years from now, we look back and say, man, we were barbaric. We used to cut people open and put metal in them. And now we treat it as a disease because that's what it is, and we can be preventative. We can treat this at an earlier stage so it never gets to the point that it's so far gone.
Those of you who are attending today, are there any questions regarding either the regulation or this new topic that John brought up of this culture expanded? For those of you who are not aware, this is happening in this country. And there's a couple of companies that have gotten far enough along for the ability to have a compassionate right to try, which is phenomenal. But in other countries, we were able to, there's a really good study that was done out of Spain last year that showed that with culture expanded dosing, which is 10-fold, 100-fold difference in dose, can actually heal high-grade partial thickness tears of the Achilles. And it starts to be super compelling. So Dr. Kirkland, yeah, are culture expanded cells frozen? And then does this render them inactive? Yeah, that's a great question. John, can you respond to that a little bit? I know you don't probably have a bioreactor at your office, but man, I wish I did, right?
Yep, absolutely. One of the companies that does culture expanded cells, they've been doing this in the veterinarian space for about 20 years. And yes, they usually are cryopreserved, but they are able to be thawed, and they're actually live when they're thawed. So they're able to be culture expanded, or they're able to grow from that standpoint. So obviously we've seen issues with amniotic tissues and amniotic cells that when they are cryopreserved and thawed and we try to culture expand them, they don't grow. But with fat cells and bone marrow cells, those are still live cells that seem to be viable and are able to grow after being frozen.
Yeah, similar to, I think some of the technology that has been done is been yet done from the fertility world, and we're using some of that technology to help with these diseases of musculoskeletal. My third question: does low dose PRP versus high dose PRP really matter? Does it really matter, or are we just making stuff up? And then the further question, I want you to help me. How do I talk to my patient about this? This poor gentleman came in and he'd had what he thought was stem cell treatments. When talking to him further, he had blood drawn out of his arm and then injected into his hip, 5 cc's, with Wharton's jelly. And oh, by the way, this was done like with less than 12 months ago. And so if you want to comment on that concerning issue as well, we can talk about that a little bit. But ultimately, my mind was like, okay, The note says that they had 5 cc's of PRP. He does recall them drawing blood, so we're going along. But how much, he doesn't recall how much blood they drew. It isn't clear in the note what kind of kit they used, how they processed it. Even in looking on their website, I didn't have any company relations that I could see from this practitioner's website. So I don't even know if he got the right dose, if dose matters, because the first time he got an injection, he had really good results that gave him at least 50% improvement. And this guy has pretty significant hip arthritis. Just recently, it was of no benefit. He felt no better, even with Wharton's jelly and PRP and all the things that he was paying for. He really hasn't felt that much better. So I did have a conversation with him about dose, but like, how do you have that conversation and not 100% throw the other practitioners under the bus? Because the guy already saw the guy, had some relief, paid the money. He can't get the money back, right? For even if that didn't work or what have you. And we weren't there with the conversation. Maybe it was a 100% legit up and up conversation. Maybe it was great product. We don't know. But how do you have that conversation with your patient? But let's talk first about, does dose matter?
So long and short, yes, dose matters. It definitely matters.
Okay, we're done. No.
Yeah. But there is a caveat. What I tell patients all the time is all PRP is not created equal. And to still our good friend Donnie Buford, dose for PRP matters. And so if you have a headache and you take an eighth of a Tylenol and you don't get better, you're gonna be like, man, Tylenol doesn't work. No, you didn't have the proper dose in order for this to be successful. And so let's talk about arthritis specifically. What we know is that when we get over 5 billion platelets, the research that's been published shows that you're going to have a positive outcome when you're treating patients and you're getting over that 5 billion mark. When you're treating patients and you're under that 5 billion mark, that research is mixed. And so that's the problem with these meta-analyses that will lump all of these together and not separate out who was over 5 billion, who was under 5 billion. And they're like, yeah, there's not enough data. There's a mixed report. And no, when you have these low dose studies, these 4 studies with low dose PRP that don't have great outcomes, you can't mix them with the high dose PRP that are actually getting great outcomes. So that's the long and short with the high dose. Now, the one caveat is out of Spain, Sanchez and Fizz, they use low dose PRP. They actually call it PRGF. They use a specific system to do that, and they get amazing outcomes. Now, the other thing is that they don't just inject it into the joint. Now, most of these studies, they're just looking at an intra-articular injection or a bursal injection. What Sanchez and Fizz does is they will go intra-articular, but they will also go into the subchondral bone. And so when they do that, they seem to be getting much better outcomes. And so if you are going to use low-dose PRP, I think then you have to look long and hard about saying, all right, how do I become more comprehensive with my treatments? Because if you just do an intra-articular injection, you're not going to get a very good outcome, is the way that I look at that.
So there's a question from Jason Epstein. He says, I have difficulty navigating working with the high school or high level or pro athlete that's going to some undisclosed place for stem cells, and why just PRP may be better, because at least I know what they're actually getting. Why shouldn't they go to get stem cell treatments overseas? Or maybe they should. I don't know.
Yeah. So I think that one is really understanding what's going on overseas or what's going on at home. So first and foremost, any Wharton's jelly, any umbilical cord stem cells, any exosomes are still considered illegal by the FDA, and they've made those statements extremely clear. And so I don't look good in orange, so you won't see me using those things, although there may be some benefit to those. 2 is looking at umbilical cord and looking at Wharton's jelly. We alluded to this earlier. We cannot culture expand that. So what does that tell us? These are not live cells that are being injected. More than likely, these are growth factors. Growth factors can be beneficial. Growth factors can have anti-inflammatory effects. But what's in PRP? Growth factors also. We've used some of those products in the past, and they seem to match up a lot with PRP. And so we want to stay in the area that is not the gray, and we want to be on the right side of FDA. And so I would say, hey, this is what FDA allows us to do here in America, and this has good data to support it. Then as we go to say, okay, what about going to Panama, going to Mexico, going anywhere to get these expanded cells? Long and short is what is the regulation there? And we've had some horror stories coming out of Mexico, out of some of these other kind of third world countries with some of these treatments. And so you have to be very careful or mindful. And then also knowing the data. Like when I look at Albert Goby's data on MFAT for osteoarthritis of the knee, looking at average age of 75, treating 120 knees and having an 88% success rate, are they going to give me a better success rate by going overseas, doing culture expanded? The data doesn't necessarily back it up. I'm willing to say, hey, I know all the data based off of your situation. We can go head to head with anybody overseas, and I'll save you a lot of money where you're not paying $40,000 to do this culture expanded procedure and getting the same outcome as what I can do for $7,000 here in the States. As we get more data out there on what culture expanded looks like, if we get more data on who's doing it in a safe, effective, route, that may be the future. But the question is, do you trust people overseas? Do you trust the regulation over there? Do you trust, what happens if something goes wrong and you're back in the States? These are all the things that you have to look at when you're looking at these things.
I struggle with this a lot, and I have the similar answer to you. And I've tried to do the deep dive on these clinics, and I've gone so far as to schedule a consultation. I didn't make my consultation, but I was like, shoot, man, I missed it. I really wanted to hear the whole pitch and the whole deal. And it's not to say that it's not beneficial. And I think there's a lot of UFC fighters that swear by it. And I don't think it's 100% wrong. I just don't know that we have data, and maybe we do have data. I'm not aware of it. I don't want to be that myopic and say, oh, just because I don't do it, it's not great. And I do think that there is a systemic effect. I just read one of the papers recently that talked about how you can get a change in your CRP, your systemic CRP, with an intra-articular knee injection. So a single intra-articular knee injection can then drop your CRP. 5 weeks later, your CRP level systemically is dropped. What are your thoughts on that? I was like, oh my God, we're curing heart disease with a knee injection? Yes, that is good doctoring.
Long and short, it depends on the situation. So if your CRP is elevated because your arthritis is so significant, and that is the source of your elevated CRP, then yeah, that makes a lot of sense. If you have somebody that's coming in with no knee pain and elevated CRP because they have some other inflammatory issues going on, and you inject them in their knee and their CRP comes down, then that, yeah, really truly does show that there's more of a systemic effect. And so I don't think that's the case for most of the things that we're doing. So I think that makes it a little bit harder. But you get some of these clinics that are overseas, they're doing IV stem cells, they're doing IV exosomes, they're claiming to drop and have systemic effects with those. I think that there's a lot of potential there. I don't know if there's any data to support it, but I'd love to see where this field goes with that. And that may be future treatments for a lot of things. When we talk about anti-aging and longevity and how do we sustain and how do we keep a lot of these things better, it might be IV stem cells, but we are not there yet.
Yeah, so I always try to judge what I would do for myself so that I can tell my patients, hey, me personally, this is my thoughts, and knowing what I know about the field, this is what I would or would not choose, right? I've had PRP. I'm a big proponent. How about that? But ultimately, would I feel confident and comfortable to get IV stem cells or exosomes? Or would I feel confident that Dave Asprey at A4M just talked about the fact that he is doing blood exchange with his younger child? And that's interesting thoughts. Maybe I should consider that. My kid's 10. Hey man, if that's something that's reasonable, cool, let's do that. Very interesting thought processes. I think keeping an open mind and really trying to clearly, I think, is probably the best recommendations. We do have some questions. Jason Epstein was really happy on how you explained that conundrum. So thanks, that was great. We have Roxanne asking, how much blood do you usually draw when you're treating a shoulder or an elbow? How do you make billions of platelets. Like, how do you get to 5 billion? What is the percent recovery of your device? And then do you have anesthesia for tendon PRP, nerve blocks, local anesthesia? Like this technical piece of it, how do you actually, if we've determined that high platelet dose is important, that we do have some markers that probably between 3.5 to 5 billion is the minimum, the floor. How do you get there? How much blood are you drawing?
It really depends on how many targets that I'm aiming for. The minimal blood draw that we do is 60 mLs of minimal blood draw. So if we're concentrating and injecting into one tendon, we'll take that 60 mLs and concentrate it down to somewhere around 4 to 5 mLs of PRP. And then we'll put it into that local area. So I typically will anesthetize the tract with lidocaine, but not the actual tendon. We sometimes do nerve blocks. If I'm doing a rotator cuff, I will either do a trapezius plexus block or sometimes a suprascapular nerve block, and then do local around that area. If we're doing a lateral epicondyle, I might do a radial nerve block above that area there to make them a little bit more comfortable. We also have laughing gas in the office. And then if we're actually doing some things that are a little bit more painful, such as subchondral or interosseous, we use things like MKO, which is midazoline, ketamine, and ondansetron. So I had 2 today and it worked great. Like one guy literally slept through the procedure. And those
Yeah,
are
MKO
things.
for the win, right? Man,
Yeah.
tell you
Uh,
what. Thanks, Donnie, for that recommendation. So tell me this, from a business perspective, do you charge extra for nerve blocks or sedation, or does that come in the package?
I have the unique ability because we are a hybrid. So we take insurance and we do cash pay. I can do some of these things. We'll book an evaluation and an ultrasound and a nerve block under insurance, and then I can use the regenerative and then use the PRP and have that as kind of cash base.
Interesting. So like a diagnostic nerve block.
Yep. And so if they're having radicular pain from their shoulder being unstable, compressing on that trapezius, then we can do a diagnostic nerve block to see if that gives them benefit, as well as then treat them with PRP.
That heard here first, folks. That's a great little tip to be able to navigate that sticky area. Obviously, you're doing separate notes, completely separate, one to insurance and one for the regenerative procedure. Is that correct?
No, and I'll document even the one that goes to insurance that we did PRP, although they don't cover PRP, but we were doing insurance-based things and that were justified. And ultimately, we had the discussion to do PRP. And so here's my separate note for PRP.
Awesome. John, this has been phenomenal. We have some more questions here from Roxanne. Do you tell your patient not to ice the treated site in order to not impair the recovery?
Initially, I tell them to heat. We're trying to increase blood flow into that area there, and ice can be a vasoconstrictor, it can decrease blood flow. That's exactly what we're trying to create. So the first 48 hours, I say use heat, use Tylenol. I have them try to avoid the anti-inflammatories. That's a whole nother side topic on whether or not anti-inflammatories can affect the difference between COX-2. There's some studies that show that COX-2 do not impair the platelet aggregation. And then also all the other medications that you can potentially take, right? Should you be stopping statins beforehand, aspirin beforehand, making sure that you haven't had a corticosteroid injection 6 weeks prior. These are all little things that you can do to try to optimize, because there's some data that supports some of that. Does diet play a part? Can you intermittent fast and help to improve your stem cell response? Different things like that can all play a part in things. Stopping the smoking, which is also a vasoconstrictor. So these are all things that some of the data is out there that can support it. But do we have head-to-head studies? Very few to really support that, though.
Yeah, absolutely. And so some of you are maybe thinking, wow, John just dropped a huge knowledge bomb on us. So now we're like super smart. We're ready to go. We're getting after that. Like, how do you go ahead and be successful? So what's the next step? Obviously, you need a system. You need to have knowledge. You need to attract the right patients, have that cash-based business. And John, thanks so much for giving us some of these really cool pearls and tips for merging that cash and insurance world. Obviously, you have to have the consultations of the patients that are interested in this, and then when you put it all together for success. I just wanted to invite you guys all to this Regen Patient Magnet Method workshop. I'm doing it this Saturday. So if you're interested in how you get patients that will actually pay you money to do this. And so you can actually give them something that will help them. Please just scan that QR code. I'd love to see you this weekend. If you scan it and register that to have something going on, you can absolutely get the replay. Ultimately, what if you want the fast track, right? Come to the Bob Live. This is right at the IOF, the Interventional Orthobiologics Foundation. For anyone who's going to be at the Interventional Orthobiologics Foundation, it's a full day of business. All our favorite friends will be there, and we'll be stepping that next step into a deeper dive on how you integrate orthobiologics and not only integrate, but succeed. You can be a shining example like John here, who has been uber successful in helping so many patients in the DC area, 7 Regen clinics, 10 Regen docs. Man, I tell you what, that is awesome. So definitely, if you're interested in taking a look at that, please get the QR code. And then I just wanted to thank you so much. Oh, Jason has a question. He says, I do not have a cell counter. So I basically always draw 120 cc's, and he uses an angel kit. Sometimes if he gets a low volume PRP, he's tempted to add the PPP. Is there a significant downside to this?
You got a great start if you're always doing 120 ml draw. I'm not familiar with the capture rate of the Angel off the top of my head. Go ahead, Ariana.
Yeah, I used to use the Angel system myself, and it sets at a very specific hematocrit, right? And so you can draw a lot of blood, and the most successful papers that were using the Angel system are drawing at least 120, usually 180 cc's of blood. And I tell you what, if you're not getting that injectate amount, unfortunately, you can look in the bag and that's where the rest of your platelets went. It's a really devastating experience to, oh my gosh, dang it. Don Buford says that capture rate is inconsistent. Yes, so it's non-linear. So you would think that it's this linear, but it's a non-linear system and it's inconsistent. Unfortunately, it's a optical sorter, right? And so there's where some of the inconsistency comes in. And he tested the PPP and there was no platelets in the yellow. So I think expanding that out using PPP is probably not a good plan. And yes, the lost platelets are all in the bag and no longer available to use. So yeah, that's always when I'm crying, because that's the only one system that I could use for a long time in my operating room. And I knew they were in there and I was just staring at them and I was sad and I was crying. And yeah, Jason, definitely send it out. There's some services. Yeah, ACP Max is a better system if you have to stay within the Arthrex system. That is a much more reliable situation. Stay tuned, because hopefully there'll be some data coming out on that and we'll go from there. But Jason, great questions. Dawn, thanks for joining. And as always, John, thanks so much for your time. I really appreciate it. This has been a really great conversation with some very good tips and tricks and pearls for success in the field. So thank you again.
Had a lot of fun. Thanks for having me.
All right. Thanks so much, guys. Have a great rest of your night.